of innovative orthopedic networking, e-learning, education, and research that was designed to fill the gap left by the absence of face-to-face meetings, courses, and other activities during the 2020 coronavirus pandemic. But Pioneer has become so much more than this in the intervening year. Pioneer is a virtual, but also very real community of like-minded orthopedists striving to help not only themselves, but one another. With the latest video conferencing and educational technology, as well as a groundbreaking online platform, SICOT's Pioneer events, activities, and resources are reaching every corner of the globe, with over 55,000 views of our webinars so far. We're forging new partnerships, signing agreements with 12 other international academic societies, and building an enduring network we hope will last for many years to come. So, what can you expect from us? Free webinars led by key opinion leaders from around the world and across all fields of orthopedic surgery and traumatology, as well as chat shows with some of the most interesting and inspiring surgeons on the planet. Opportunities to take an interactive role in these webinars by participating in service management system will host podcasts, an online version of the famous SICOT diploma exam, virtual training modules, surgical technique courses, a discussion forum, and much, much more. We hope you'll join us on this pioneering journey as we push the boundaries of what is possible in online orthopedic education together.
Good morning, good afternoon, and good evening, ladies and gentlemen. So welcome to the SICOT Pioneer webinar series, the first of many in 2025. I'm Dr. Margaret from Hong Kong, and I'm the chair for the SICOT Education Academy. Before introducing today's chair and faculty, I would like to share some background on the SICOT Pioneer initiative. The SICOT Pioneer is part of the SICOT Education virtual platform, which is launched in June 2020. Since its inception, we have organized over 85 webinars and 6 TED sessions. To date, the platform has garnered 45,000 live views and over 73,000 on-demand views. We are also very proud to have a Pioneer fan club of nearly 10,000 members. As you heard from the video, if you'd like to explore more from our previous webinars and other education activities, please visit the SICOT website at www.sicot.org. We encourage you to join as a member to access these resources on demand. Today's webinar is organized by our subspecialty sports committee led by Dr. Umer and Dr. Dersin Basadurgyo. The focus of today's session is the management of middle-age osteoarthritis of the knee. We're honored to have esteemed faculty from all around the world, including Dr. David Parker, the president of SICOT, as well as Dr. Reha Tandogan, which is the past chair for the SKEK. So without further ado, I would like to hand over to Tatsun, who's going to talk to give the opening ceremony and introduce the faculty. Thank you.
Okay, thank you very much, Dr. Ford. So we have a great faculty today. Mainly, it is chaired by me, but the moderators will be Dr. Reha Tandogan and Dr. Umer, and also from Belgium, Rene Verdonk will join us, and Fabio from Italy, and Claudia Arias Calderón from Peru, and Dr. David Parker from Australia, and Dr. Seow Hui Teo from Malaysia. So it is a very international, intercontinental meeting and a brainstorming about the middle-age osteoarthritis with case discussions. Also, I would like to thank you, the main sponsor of this activity. This is Bioventus company, which is with their product Drolane, they are supporting this event. And as you know, Drolane is the FDA approved for symptomatic treatment of the knee OA in the United States, but also in Europe and the Middle East. It's being used for the knee and the hip, also for the osteoarthritis. with more than 2 decades of use in knee osteoarthritis with long-lasting pain relief based on degradation resistance, Rene is a safe FDA-approved product. So now, after thanking our sponsor, I would like to continue and give the word to Dr. Reha Tandogan to begin the case presentation, ask questions to this faculty. And also, we are waiting questions from you online, and we'll try to do our best and answer the questions which are coming from you. Dr. Tandogan?
Good morning, evening, and night, everyone, because we are truly an international faculty. I will start the case immediately. So the first one is a case of a male, 36-year-old male. He had an ipsilateral hamstring ACL reconstruction and a medial meniscectomy about 6 years ago. He has had recurrent instability without a major trauma. He complains of effusion and medial pain. He's a recreational runner and wants to be active. So his physical exam reveals no joint hyperlaxity or hyperextension. He has a full range of motion. He has some effusion, 2 positive pivot shifts and anterior drawer tests. The collaterals are intact. He has medial joint line pain, which is slight, and he has a slight atrophy of the quadriceps muscle. So his x-rays look like this. As you can see, he has a slight medial joint space narrowing, but that's about all. And his alignment is something like this. So maybe, Fabio, would you like to take on a few words about the x-rays before we go on?
Well, the first thing it's clearly noticed is the fact that on your left you can see an increased tibial slope, posterior tibial slope. So that's what certainly comes to my mind. On the other side, the normal axis, I wouldn't do any correction on the medial line, even if you said that the patient has some medial pain, maybe due to the fact he still didn't get back to his normal quadriceps tone. But it's really important to see that we have maybe a double degree in the tibial slope.
Yes, so I think maybe I would ask anyone, I think it should be a standard of care for obtaining long leg x-rays, especially on our patients who are undergoing to revision ACL reconstruction. So I think one of the points is that I would like to make that is we should have a full length x-rays. So let's go on with the MRIs. You can see on the coronal MRIs that he has some slight medial cartilage loss, but accompanied by a medial meniscal loss. His sagittal X-ray MRI scans on the lateral side show an intact lateral meniscus. The cruciate ligaments, you can see the PCL is intact, but the ACL graft is gone. There doesn't seem to be a tunnel widening. The medial compartment is like this. You can see a small osteophyte on the medial side here with some cartilage loss, but the cartilage loss, I think, is a partial one. So, and this is his coronal scan, transfer scans. You can see the fusion, you can see the implant. And so this is what we have at the moment. So to summarize the problems, we have these. We have a high posterior tibial slope, a partial medial meniscal loss, a failed hamstring ACL reconstruction. So David, would you like to take on the issues below and tell me what would you do?
Sure, thanks, Reha. I think the other point here is that it's a suboptimal ACL reconstruction. So I think when you have an atraumatic failure of an ACL reconstruction, you look at the previous surgery, the tunnel position, and other things that may contribute. So the other things here, it sounds like his collateral ligaments are stable, but he has a deficiency of the posterior horn of the medial meniscus, which will contribute to anterior laxity, and he has a very big tibial slope. So I think in this situation, even though the previous ACL could be improved with the revision procedure, if you do just the revision with that slope, it will probably fail. So in my hands, he would have a revision ACL reconstruction. The femoral tunnel position needs to be improved. I would add a lateral extra-articular tenodesis, and I would do a slope-reducing osteotomy anterior closing wedge.
Right. David, what would you select for a graft? His hamstrings are used for this side, so what would you choose?
I would probably use quads here. I mean, you can use a BTB, but it gets a bit complicated when you're doing that and a slope-reducing osteotomy. So I'd probably talk to him about a quadriceps tendon graft. How old is he?
36.
Okay. In the older patients, sometimes I use allograft too, because I think their risk of traumatic re-rupture is pretty low. So I think graft choice is always a discussion you have with the patient about the pros and cons. But I probably wouldn't go to his other leg. I'd use either allograft or quads tendon.
I think my co-chair Omar But also has some graft selection options, like he's using the peroneal tendons. Any comments on that, Omar?
Yeah, thank you very much. I think in this part of the world, because we don't have availability of allograft, so I do discuss this option with the patient if they don't have any ankle problem. And we do have now 5 years RCT published showing that peroneus longus is quite a safe graft. So in revision case, especially when you're already doing too much on the knee with lateral extra-articular tenodesis, posterior slope correction, going outside the knee joint and taking peroneus will not be a bad option. I would also rule out infection. As you can see on the MRI scan, there is a huge amount of fluid infusion. So I would do CRP, ESR. There is always a hidden infection in failed cases, which I come across a lot.
Okay, so I'll just move on, and then I'll ask Rene what he would do about the slope. So we did an infratuberosity slope changing osteotomy, and I'd like to ask Rene his opinion about where he would do his osteotomies, supratuberosity, taking off the tibial tuberosity, infra like we do here. Rene, any comments?
No, I would do infratuberosity osteotomy. I think that's the easiest way. Maybe using a timely screw to fix it, and then a plate. I think that would be the easiest option.
Right. This is what we did. We
changed exactly,
and then put in the plate. Anyone would do the staged or like we did simultaneous with ACL reconstruction? Please raise your hand if anyone would like to do it staged. Probably not. So yes. We in a single stage and then did the revision. The graft I used was a hamstring from the contralateral side because we had so much quadriceps atrophy on this side that I didn't want to disturb his extensor mechanism again. But of course, we can discuss the graft options until the morning. So, this is what we did in the end. So I'd just like to have a brief comment on the combined osteotomy of slope-reducing osteotomy and the ACL reconstruction. There are about 6 studies in the literature, about 130 knees. The usual indication is a posterior slope greater than 12 degrees. Most of them are concomitant with the ACL reconstruction performed at the same time, and the rest are staged. For most of them are primary cases, but some would also, most of them for revision, some of them for primary cases. So I'd like to ask Tahsin, would you do a slope-reducing osteotomy on a primary case? Because there seems to be a controversy here.
Although I know some people doing the primary cases with high slope, doing the slope correcting osteotomy with the ACL reconstruction, I don't do. Because we know that it is 3 or 5-fold increase in the ACL failure rates. However, I have a lot of patients who had a little bit increased slope, maybe for 20 degrees, even it's rare, but when we have, I don't have any experience with the primary ACL reconstruction with correcting the slope. So I still do not advise it, but we know that if you have an ACL failed knee, so we have to search what is the reason of failure. Is the rod tunnels, is the neglected posterolateral corner, or it is a highly increased tibial slope. So if it is a revision case, of course, like David, I would add also lateral extra-articular tenodesis and also correct the slope, which would be a reason of failure then, and do a revision ACL, but not for primary cases in my practice yet.
Okay. Claudia, question to you. Do you really need to do a lateral tenodesis if you're also reducing the slope? If you're, what are your thoughts on this?
That's a very good point, Reha. That was a point that I was going to ask to.
No. Claudia, yes.
Nobody. Sorry.
Oh, that's okay.
Go on.
Thank you. So, well, I think that this case is really important just to check about the cause of the failure. I think this is the most important thing that we already talk about that. I used to make a stage 1, so I make into stages. Normally, in this case, revision. But I use normally a supratuberosity 1. I think for me is a little bit easier. I have better consolidation. I have not so much problem with that with the staples in both sides. My only concern will be the patella height. But in any case, I think if we are going to discuss in the primary cases, if we have a slope, if we have more than 12, we know that exactly this is a risk factor of a failure. So there are literature already that discuss that probably just to protect this in a primary case, if we are not going to make osteotomy, probably a lateral tenodesis will work just to protect this. So in any case, if I'm going to make my correction of the tibial slope, and in the first stage, I will only make this. And in the second stage that I make the reconstruction, the revision, I will use the lateral tenodesis, of course.
Okay, so you will add tenodesis. Fabio, you're, I think, opposing this?
No, I wanted just to emphasize some of the words that Taksin said, because I think that obviously we are focusing now on the posterior tibia slope, but when we have to face the revision, we have to understand correctly which ones have been the cause of the failure. So not just focus on the posterior tibial slope, but check everything. And you know that obviously, maybe lastly, we think about the correction of the tibial slope. So the tunnels, the positions, and all that stuff there. I just wanted to emphasize that. And also, finally, I confirm that I reserve the correction of the tibial slope just in the revisions.
Okay.
It's like my approach to primary constitutional varus knees with ACL injury. In my primary cases, I don't also do HTO with these ACLs. So it's the same for me.
Okay.
For the slope.
Okay. So I didn't do an LET in this case, and I thought it would be too much surgery. Okay. So David, it's you now. This is your case. I will advance your cases when you tell me to do. Second one.
Thank you, Reha, and thanks for letting me present this case. Greetings to everybody around the world. So this is a patient who came and saw me about 5 years ago. He's 45 years old at the time. Now, he'd had surgery elsewhere for a multi-ligament injury about 20 years ago, and then about 15 years ago, he had a revision ACL reconstruction. No specific complications and no further injury, but over the last few years, he's just had a gradual progression of problems with pain. He's noticed an increasing deformity. He doesn't really complain very much about instability. And then on examination, he's obviously got varus alignment. He walks with a thrust. He's got a pretty good range of motion. And he had a PCL that was grade 2 with a good endpoint, but the knee was otherwise stable with a fixed varus deformity. So if you can go to the next slide. So these are his x-rays. So I'll leave those up there because I think the question here, I mean, I think it's pretty clear to everybody. He's got a big varus deformity. You can see his weight-bearing line falling outside the joints. You can see that it's about 14 degrees of varus, and you can see his joint line angles there. And the question I would have, and maybe I can put this question to you, Reha, is this a person, a lot of places in the world, this person would get a knee replacement. Do you think this is a candidate for a joint preserving or a joint replacement procedure?
Yes, I would still go for a joint preserving procedure if it's not bone on bone. If it's a bone-on-bone arthritis, I wouldn't just hesitate because of the patient's age, which is young. But here, I think we still have some joint line that we can save. So I would go for a joint preserving option in the first setting, especially if he's a male and he's a manual worker and he's active in sports. I would go for a joint preserving option.
And so maybe go to the next slide.
Yes.
And there's his MRI scan, so you get a better idea of his cartilage wear. And the lateral compartment looks quite well preserved. The patellofemoral's got some trochlear wear, but not terrible. The medial compartment does have areas of full thickness cartilage loss. Does that change your opinion?
Depending on the patient's activity level, if this was a sedentary patient and pain was the most important one, I would maybe go for an arthroplasty. But here in this case, he's a young guy. I would first try to do something joint preserving.
Okay, thank you. Claudia, would you agree to do a joint preserving procedure for this 45-year-old active person?
Yeah, I think that the most important is just to talk with the patient, exactly what he expects, because he's expecting about probably is an active 45. So in any case, I will first talk with him, exactly explaining what the pro and cons with any procedure, but I will try to go to preserving, not to a replacement, not in the first case.
I think that's important, the discussion, pros and cons, and this person was quite keen to stay active and also keen to retain his own knee joint. So that's what we did. I'll talk to you through that in a minute. Technically, how would you plan this case, Claudia? What would you plan and how would you work out what you're going to do?
It's a very big deformity. So we have more than 10 in the tibia and also in the femur. So probably I will plan with we don't have any program to make like an app or a program in the computer to make a planning. So we make by ourselves. So with a long panoramic one is perfect. So we just make the angles and then plan to correct the deformity. In this case, for me, I think that the deformity is too big just to manage it only one bone. So probably if we are thinking just to make just a correction on the tibia side, could be that I will be just really in the limit of the correction. So probably I will start to think if I can do something to the femoral side also. So maybe I can push too much the indication for a correction only in the tibia, but probably with this kind of deformity, I will try to make both eyes.
Okay, so, and what would you do on the two sides? On the tibia, you would do what sort of osteotomy?
An open wedge, just to correct. With an open wedge, when I use that, I try to correct no more than 10, 12 will be my limit, no more. So if I need to correct more, I just go to the femoral side. So to make, if I make one open, I make the closing one in the other one, just to correct and to maintain the alignment. But the thing is, I think that the most important is how much we can correct and not to create another deformity, right?
Sure. Okay, thank you. Thank you. That's great. We might move on and I'll show you what we did. So if we go to the next slide, so this is just to illustrate the point of what happens if you try to correct it all on the tibial side. So this is the planning software that we use. So if we plan to do the correction to 2 degrees of valgus, which is what we normally aim for in arthritis, then we will end up with a wedge on the tibia that's going to be 26 millimeters, which is a bit beyond most of our comfort zones. But we'll also have a 10-degree valgus tilt on the joint line, which has been shown in lots of studies to have worse outcomes for osteotomy, but also we need to think about the next operation, which is a knee replacement, and that will make the knee replacement technically very difficult. So if you go to the next slide, so as Claudia said, to try and make those corrections more manageable, but also to recreate a more normal joint line, we planned an opening wedge on the tibia to create a fairly neutral joint line, so about 90 degrees. And then we create about 2 degrees of valgus in the femur. And so we have an opening wedge on the tibia, a closing wedge on the femur. We get the correction that we want. we keep a normal joint line, which makes better function and also better knee replacement later on. And also we don't lengthen the leg so much because we're closing on one side and opening on the other. So that's how we do our planning to work out whether it needs a 1 or a 2-stage procedure. And the clue from the original x-ray is if the weight-bearing line falls outside the joint, there's a pretty high chance you'll need a double level osteotomy. So if we can go to the next slide. So we do this with PSI guides, which we've done a lot of work on showing that they're very accurate. So you see the femur on the left and the tibia on the right. Go to the next slide. So that's the femoral side of correction, closing wedge. And then on the next slide is the tibial correction. So opening wedge on the tibia with allograft bone. And then go to the next slide. So this is him at 8 weeks post-operatively. That's what we see. So they actually recover. If you choose the right patient, obviously, they tend to recover fairly quickly. And you go to the next slide. So all of our patients get a gait analysis pre and post osteotomy. So on the left side, the graft with the red line and the black line, the red is the adductor moment, so the force is going through the medial compartment preoperatively, and black is how much has been reduced after the surgery. And you can see on the models there, the green line preoperatively is the ground reaction force, way medial, and afterwards it's going through the joint, through the middle of the joint. So that's what we aim for, and that's how we make sure we get the alignment correct. The next slide, please. And just a little bit of longer term follow-up, because obviously we always present these short-term follow-ups. So that's his x-ray. He's doing well, and he's actually probably about 4 years down the track now. So, and you can see his joint line's fairly normal. They've healed well, and he's had a good functional outcome. So I'll hand it back to you, Reha, if you want to have any discussion around that.
Thank you. I just want to ask Theo, I see that you have a staple there, probably for a hinge fracture, especially for a young male with very hard bone and a lot of correction. We can see these. Theo, do you have any tricks to try to avoid this in happening?
Yeah, hi.
Yes.
Yeah, sorry. I'm a bit left out just now because host didn't let me in. Hi, everybody. Yeah, so in case of this, I think for me, I like to use II to make sure that I doesn't have to cause a fracture over there. And when I make a saw, when I make a cut, just make sure that I use my II to check so it doesn't cost more than what I wanted to. And also not to make a too proximal cut. I think all these can be done through a pre-op planning, and during surgery through an II with guidance. I think it's very important.
David, do you use the golden K wire?
So Reha, that staple was there before. That's not a hinge fracture.
Okay, sorry for that. But just as well, because I just wanted to open the discussion for that.
Yeah, that's an important point. So I think Seow made some good points there. Obviously, planning the osteotomy so you get close enough to the lateral cortex, but leave a hinge. We do use a hinge pin that comes with the PSI guide, and that's been shown to help protect as well. I think the other really important point is that you just look for it very closely when you finish your correction, and when you're screening with the fluoroscope, you rotate it and make sure you don't have a hinge fracture. A hinge fracture is not, you want to avoid it if you can, but the worst thing that can happen is if you have it and don't recognize it. And if you do recognize it, then a staple or a small plate will stabilize it and you won't have any problems. So avoid it if you can, but make sure you recognize it if it happens.
Great answer. Thank you. So I just want to sum up this double level osteotomy. The indications have been clearly described. We know that only about 1/3 of the Varus knees have an isolated tibial deformity, as he has shown so elegantly. The rest have a deformity both on the femur and the tibia. So we know that we should avoid joint line obliquity more than 5 degrees because that is associated with worse outcomes. Therefore, about a third of our patients with varus alignments will need double level osteotomies. And as you have shown us, PSI is a great tool to plan and execute these osteotomies.
I want to ask a question to David. Would you consider or plan to implant removal in this patient? Because in 15 years' time or 20 years' time, the probable joint replacement would be possible for him, and simultaneous implant removal and knee arthroplasty is not advised. So also we know that in the distal femur, lateral part is a little bit irritating for these patients a lot, and implant removal is giving a better clinical. So what do you think about implant removals? What is the rate of your implant removal in your HTO or VFO patients?
The rate is about 20%. And then my approach to implant removal is that I do it if there's a reason to do it. In other words, if I have a patient who's 1 year, 2 years, 3 years down the track, and they say their knee is great and they're having no problems, I talk to them about the reasons for doing it, but I don't tell them they should get it done.
Yeah.
And if they do need a knee replacement, then I do it as a staged procedure. I agree with you entirely that the lateral plate tends to be more irritating, and in this particular patient, we have taken his lateral plate out, but his medial plate wasn't bothering him, so we left it there. He knows that if he needs a knee replacement in the future, it will need to come out as a staged procedure. So I don't do it as a routine. I do it based on what patients want, which is usually based on their symptoms.
I think also that's a great point.
Can I also have a question to David?
Of course.
Okay, it's just a curiosity to you and to all the other colleagues. Obviously, you did a great work, and not injustice in this case. I was thinking, what do you do intra-articularly? I mean, you perfectly know that there's a cartilage damage. We saw some bone edema both on the medial tibial plate and on the medial femoral condyle. Do you take care also of repairing the cartilage defect? Do you maybe add, my love for cartilage repair and regenerative medicine? Do you think to add some bone marrow injection inside the bone edema, or you just count only on the joint preserving and deloading effect of the osteotomies? Do you ever add the two situations? I would like to have the opinion from you and all the others.
Sure. So we have shown some time ago, we published in American Journal of Sports Medicine that if you just do an osteotomy, you get cartilage improvement on the medial side after 2 years. So it's very important to make that point and compare any cartilage treatment to that. So when people say they get an improvement with their cartilage procedure, you have to know what the baseline is. And we've done studies in the past where we've used ACI in arthritic knees, and some of them do well, but in general, it doesn't get a better result than just an osteotomy. What we're doing currently is that we do an arthroscopy, we do a debridement, and we're doing a microfracture or subchondral drilling, and we inject bone marrow aspirate concentrate.
Yeah.
But I tell patients this is a study that we're doing, and all of our patients have a preoperative high-resolution scan, and they have one at 1, 2, and 5 years. So if you ask me again in about 3 years, I'll tell you if it makes any difference.
Thanks a lot.
Thanks.
That's a very good point. Well, I usually also think that adding the repair of the cartilage, especially in the first months post-op and the first, let's say, also 1 year, can be useful and, let's say, also reducing pain and making rehab more quick and easy at the beginning of the story. That's my thought, and that's why normally I add also the cartilage repair. Well, this was a most complicated case, so obviously it's another issue, but just to have the idea. Thank you.
Thank you. Thank you, Fabio.
I have one question to add to Professor David Parker. So if I have the similar case here in Pakistan, which I see a lot, with slight stiffness, he's got failed ACL, 45 years of age, same deformity, slight instability with double level osteotomy, correcting the deformity, will you still go ahead and consider doing an ACL reconstruction in the same go? Because I come across quite a few cases in which when you correct the deformity, when the patient comes back and see me, they don't want their ACL to be done. I'm
I think
talking about someone not 45, even younger than 45.
Yeah, I think for me, if they have a big enough deformity that requires this type of procedure, I don't think an ACL reconstruction is usually necessary. This patient his ACL was actually intact. He had PCL laxity. I think there are things you can do with the slope with an ACL reconstruction, with an ACL deficient patient that can probably reduce the need for reconstruction. If I have the most common situation that I do an HTO with an ACL is if I have someone who is starting to get some medial compartment degenerative change, so not bone on bone, but they've maybe lost the meniscus, cartilage lesion, and they have an obvious Lockman and a pivot shift test, and they have instability. So that's the one that gets an ACL with an HTO. But if they've gone more towards the arthritic stiff knee as a longer term consequence of ACL, that does not get a reconstruction.
I think Umer will just see the case right right now. The Claudia's case is something about that. So Claudia.
Okay.
This is now Tassin's case.
Tassin, yes. This is a 31-year-old male. He's from patient from abroad. His complaint is from his right knee with recurrent instability, pain and swelling at the knee. When he was 25, he had an ACL injury, but in his country, some doctors said some bundles are intact. So if it is not doing a severe sport, it's not necessary to have an ACL reconstruction. So after 3 years, he had a medial meniscal tear. So he had a surgery for not an ACL, but only a subtotal medial meniscectomy. When he admitted to me, the X-rays, weight-bearing AP and Rosenberg, and lateral X-rays and the orthorentinograms you can see, although he has a slight varus in his left knee too, like 3 degrees of mechanical axis, he has like 8 degrees of varus in his right knee. So my question here is to Teo. When you are considering an ACL failed or ACL neglected knee, do you always have orthorentinograms? And when do you consider to in your treatment the HTO as an option when he has a slight varus? Is there a degree? If it is more than 5 degrees, if it is more than 7 degrees, how do you consider an HTO?
Yeah, I think this is quite a challenging case because number one, first you're asking like when will you do a long leg view, right, for these tough patients that comes to me. So in this case, this patient has a long standing of an ACL injury that was 6 years ago. So I see any patient with a long standing of injury, I think I need to check the alignment. And also, of course, clinically, we have to take a look. But I guess clinically, probably you couldn't catch this because it's quite a malalignment. And when you talk about having to do a HTO in a primary ACL in this case, I think it's difficult because it's not too much of a malalignment. And I think in this case, most probably in my practice, I would tell the patients that the risk of re-tear is high because of his malalignment issue. And then I would actually add that, this is for my primary ACL reconstruction in this case. And we'll see how it goes in the future. But in the first setting in primary, I think HTO is a bit not so much in my practice. Yeah.
Okay. And my question is going to Claudia again, similar. If you're at your physical examination, it is very important for me. If you see that the patient has instability in the examination and also medial joint pain, the main complaint of the patient is both pain and instability, then how would you consider the treatment options, Claudia?
Yeah, I think this is a really nice case because we saw this a lot. And this is like a natural history of a meniscectomy, right? So this patient have an ACL injury before. He had already medial meniscectomy. And if you can see the long-standing X-ray, there is, for me, it's a constitutional varus. I have a lot of that in my country. So normally, if these patients come with the very first ACL injury with no previous surgery or meniscectomy, probably I will have the same, even just 1 or 2 millimeters degrees of difference between both knees, probably I will not go for an HTO. But in this case, with this kind of medial meniscectomy already, with the ACL, I will talk to the patient that this will protect this surface, the medial compartment. So in this case, even if I have just 1 or 2 millimeters difference between each knee of degree of varus, I will go for an HTO, just explaining that I want to just to protect the medial side because of the meniscectomy. So that, I think that will be my approach with this patient.
So this shows that the decision making for the surgeon is mainly coming from comparing the complaint knee to the other knee. So if there is an increased varus than the other knee on this knee, this means there is early osteoarthritis signs for this knee, and danger has begun in this young patient. Here you can see the MRI. So I would like to ask to Umer, what would you consider in this one? Okay, we have a neglected ACL injury, and also we had a cartilage injury in the medial compartment, and also we had a loss of meniscus. So would you consider to replace meniscus with your other surgeries too, or do you consider anything for cartilage?
I think I agree with my colleagues that the varus is not that bad, and for the primary condition, doing an osteotomy and ACL reconstruction, especially in a scenario like that, is probably just too much taking on board. But if you look at the cartilage on the medial side, it's not bone on bone. There is still some cartilage on the medial side, and maybe that is the reason the patient doesn't have that much varus. My choice will be to do a meniscal transplant with ACL reconstruction rather than an osteotomy, which obviously in this part of the world we don't have. And that's the reason we are looking at autograft to use for meniscal transplant in the form of either hamstring or whatever graft we can. But in this case, I don't think so osteotomy will be that much valuable. Maybe a meniscal transplant will be a better option for this 35-year-old gentleman.
But there is a overload in the medial compartment in this patient. So doing a meniscal transplantation, also adding a medial transplantation, do you think that this overload in the medial compartment will give a risk on this overload in the medial compartment to your transplanted meniscus?
So we need to do a stress examination on X-ray to see how much.
Maybe move on with what
is it stiff or is it opening up? And obviously there is something.
Okay, so my treatment choice was doing a simultaneous ACL reconstruction and HTO for this patient. And also, like David, I always do a debridement in the cartilage for unstable cartilage fragments. And also I do a microfracture, and I do also simultaneously a bone marrow aspirate concentration injection in these knee. Also, we are now around publishing, David, the results of second look arthroscopy results with BMAT injected, no injection knees with HTOs. So I think slightly better views in the second look arthroscopies we see in when we add an orthobiologic in these knees, but in clinical, it doesn't affect the outcomes. So my preference was taking the knee to the natural alignment. So the first osteotomy I did was in 2001 when I was just an orthopedic surgeon. So I was always defending the against the Fukuda line nearly and making all my patients the natural line at that year too. So I was right after years. What do you think about the correction degree, David? Do we always do the natural alignment?
Okay, so just a few points in terms of the decision making. I mean, as doctors, when we're making decisions, we need to understand what happened in the past and be able to predict the future. So what's happened in the past with this person is they've had a natural history of an ACL deficient and subsequently medial meniscal deficient knee, which is medial compartment arthritis. And you can see that on the Rosenberg view. You can see it on the lateral X-ray where they're eroding posteriorly. So the natural history of that moving forward is that their medial compartment arthritis is going to get worse, and that's going to be their main problem. And doing an ACL reconstruction will not, there's no evidence that that will change that natural history, okay? So the ACL reconstruction will help their symptomatic instability, but it's not going to help the natural history of their knee. So I strongly agree with you doing the osteotomy, and I think you could make an argument for doing an osteotomy and reducing the slope alone, or an ACL with an HTO. Now, if in terms of the degree of correction, I think that it depends on what you're trying to achieve. Any correction will reduce the load on the medial compartment. You just have to understand how much you want to reduce it. And so we know from our own studies that if you want to equalize the forces between the two compartments, that is 1.5 degrees of valgus, all right? If we want to get a good result with our arthritic patients, it's about 2.5 degrees. For this patient, I would probably take them to about 1 degree of valgus, even if it's not their natural alignment, because that will give them a longer term outcome. So that's what I would aim for in this patient. And again, we do gait studies and we're trying to predict the best alignment. But if you want to at least equalize the forces, you need to go to about 1.5 degrees of valgus, which is about 55% if you want to use the percentage scale.
Okay, thank you. The next slide, and you can see the results after the implant removal. The patient is still doing well. It's been 4 years only, and he's in contact with us. Thank you very much.
Thank you. I just will end with this case with a systematic review of a combined HTO and ACL reconstruction, which says that we have good outcomes, basically. So let's move on to Claudia's case. Claudia, would you like to take over, please?
Yeah, perfect. Thank you very much. Thank you for letting me presenting this. So this is a male patient of 50 years old. He's a traditional farmer with a very heavy activity in field. He worked in the highlands. He have a middle compartment pain, and he also felt given away, feeling and swelling. He used to have a lot of previous treatment like amlod brace, steroid, hyaluronic acid with no improvement. He's not a really good patient. He have a really low degree of education. He just finished primary school. He works in the field, and this is the most important thing for him. So he just come with this gait, with this deformity, with a really good range of motion. But if you can see, we have some lateral instability and an anterior drawer one. So he was going with a lot of doctors asking what kind of surgery I will have. I only want to have just one and nothing else. I want to go to work to my field, and he have really big and heavy activity. So the next one, I think we have the X-ray there. Okay. So we plan and we make a long-standing one. We have a degree, I think 14 degrees. Can you pass this, please? I think we have the deformity there. Okay. Okay, just back. Okay, so there we have a patient with this kind. We can see a medial impingement, but not bone on bone. We can see a little bit of the patellofemoral joint was really okay. We can see a Varus knee is completely different with the other one. And also we have some instability. So we have posterolateral one and anterior and the ACL also. So with this could be your approach. Maybe you, Dr. Reha, can have any chance.
Yeah, I think we have, yes, a double varus, which is chronic ACL leading to a varus thrust and posterolateral opening. So my choice would be to decide on if I was going to do just an osteotomy or add an ACL or an posterolateral coronary reconstruction. So my thoughts would be in this kind of patients, if I was going to do an osteotomy and a posterolateral reconstruction, I would stage it. I would first do the osteotomy and then do the reconstruction at the same time, because I think doing all three at the same time is too much.
Okay, just go a little bit through. So this is the femoral. Can you, and the other one? Yes. So we were talking about the joint line obliquity. and this patient have 5. Okay, so we were talking about that this could be a really risk failure for an osteotomy. So this will change your plan in any case, or you will go still with this osteotomy?
No, I think 5 degrees is okay. I don't think we will change his joint line replicates too much with the osteotomy. And as you can see, this is I think, arthroscopic.
I want to ask a question. Do you consider a stress X-ray opening on the lateral side to decide the degree of the medial opening wedge?
Yeah, we used to. Unfortunately, at my hospital, they make really bad stress X-ray, so we have to make it. But we usually do with the C-arm in the OP room. So in this patient, we just try. He only wants one surgery. Okay, he doesn't want to make more things. So in this case, we plan a biplanar osteotomy. So this is important to know that in any case with an osteotomy biplanar, we can change posterior slope and also in the coronal way. So with this change in the hinge of the saw, we can plan and we can correct that. So in this case, we don't make any reconstruction of ligament. We don't make an ACL. We don't make a posterolateral one. We just make the osteotomy biplanar just to correct the slope and the coronal view. So we can see the results that you have in the next slide, please.
Mm-hmm.
So we have a full range of motion. He have a really good gait. And when we check stability of the lateral side and even the anterior drawer, we can see a correction of the deformity. He is now totally happy because he can work. We don't know exactly what is going to happen with the ligament insufficiency. I think he doesn't feel anymore. I think you have the other one, yeah. So he's completely stable. And for me, this is a thing to point for discussion. How much we can manage ligament, or how much we can indicate where is the limit just to plan just an osteotomy, just to correct the stability of the knee. So in this case, works really good. The patient is happy. But when are your limits with the joint line? We correct that. We have a really a valgus of the tibia, so we can correct. The patient feels really okay. But for me, it's like a little bit for discussion. How can you manage this limit? First, for the joint line that you can correct with 5, it's okay. And the second one, for the ligament stability. So this will be your approach. So what do you think, Dr. David? Probably you make something different.
Thanks, Claudia, and very nice case. And I would have probably done exactly the same thing. And I think there's a few important points here. Firstly, that this patient had a weight-bearing line that was just outside the joint, so not dissimilar to the case I presented before we did a double-level osteotomy, but the joint line angles were different here, and there was a big joint line congruency angle, so a big lot of lateral opening. And that is usually from some chronic attenuation of the lateral ligament, not the posterolateral structure, the lateral ligament. So you need to take that, and you don't need to remove that completely when you're calculating your correction, but you have to take that into account. And particularly, our research would suggest if it's more than about 2.5 degrees, you need to look at, and the way you can do it is look at the standing X-ray versus the supine X-ray, and take the difference of those, and then you subtract that from your correction. This patient also had, I think, 1 degree of valgus in their distal femur. So where you've corrected your MPETA to 92, that will give them about 3 degrees of valgus if you use the arithmetic HKA. So and in terms of the ligaments, certainly when this person, I mean, you watch him walking, he walks stiff, he's got significant arthritis, he does not need an ACL reconstruction. If you reduce his slope, you'll improve the contact point when he's standing, and you'll help his stability. And when you bring that weight-bearing line into 3 degrees of valgus and reduce that adductor moment, there won't be the stress on his lateral side that causes the varus thrust. So that doesn't need to be addressed either. So I think everything you've done mechanically with the bone, and this shows how powerful an osteotomy can be, is able to compensate for the ligamentous laxity. Whereas if you have someone who has a varus thrust, a well-preserved knee from lateral sided damage and an ACL deficiency, but their knee is normal, they're the ones that I would correct to neutral and do the ligament reconstructions. But this is more of an arthritis case.
Yeah, and this is important
yeah.
just to know about the hinge, about how you can control if you make just in the same plane or you go anteriorly, just to control exactly if I want to open more posterior, so I can control the posterior slope, right?
Yes, Claudia, I was going to comment on that because
I think we can move for the last case. I think we are in limits.
we
Reha?
have 2 minutes, so I don't think we could do this one. But if you want, we can just try.
Yeah, one more case, please.
Okay, so 57-year-old female, mild left knee pain for several years. Here's a pop while kneeling 2 months ago. Pain is not responding to conservative management since that time. She's very painful, slight intermittent swelling, and no mechanical symptoms. So, I'm sorry. The physical exam is she's slight, okay, not really overweight. She has a varus, physiological varus alignment, maybe a little bit more, medial joint line pain, slight effusion, the ligaments are intact, and full range of motion. So this is how she looks like. You can see that she has varus on the tibial side. Her LDFA is normal. The weight-bearing line is passing through the medial compartment. And as you can see, she has an early arthritis, which is not bone-on-bone on the medial side. So these are her MRI scans. As you can see, she has a root tear on the medial side and also a varus deformity. So back to everyone, this is what her scope looks like. Fabio, root tear and varus alignments. What are our options?
Oh, that's a good case. Obviously, it takes us to understand what I want to do. Probably I would go for the repair of what I'm seeing now of the root here, and go also for an osteotomy, a medial correction of the varus deformity. It was, you said 56 years old, that was correct?
Yes. Mm-hmm.
Yeah, that could be an interesting discussion depending on the, let's say, type of the patient. I can see also some cartilage damage above it. And obviously, as I said before, I would probably address also that. She's an heavy patient, just...
Not really, BMI is 26, so she is slightly overweight.
From my first ideas are these ones. Maybe we can have some additional...
Okay, and you had an osteotomy, right?
Yeah.
At the same time, in the same setting, right?
Yeah, absolutely, yes.
Okay, anyone else would like to comment on this?
Yes, I want to ask a question. When I would do the same thing, repair the meniscus and do the HTO. However, if this patient, if you do perform only an HTO, or my first question, what is the difference? And the second question is, if this patient was 75 years old, what would be your treatment option?
Okay, 75 is a uni for me. I know it is outside the classical indications for a medial uni, which is not bone-on-bone, but we're seeing papers from Japan coming up saying that root tears unresponsive to conservative treatments, elderly patients, slight arthritis, not bone-on-bone, they go for a uni, and we have the same experience. So if she was older, I would have gone straight to a uni. And the second question is just doing an HTO and not doing anything else. Well, the literature seems to support that. There is no difference between adding an HTO or a root repair to an HTO, but the opposite is true. I can tell you here, if you do an HTO, you increase the rate of healing of the medial meniscus. So we're not looking at symptoms, but we're looking at the healing or preservation of the meniscus. Then I think performing an HTO would also increase our chances of success. Anyone else want to comment on this? Umer,
we are looking in preserving the joint. So that's the reason why the addition of the meniscal repair.
Yes.
If the knee is biologically healthy, age I think is not a limit. We do now quite commonly even ACL reconstruction in 60-year-old, 57-year-old who are physically very fit. If the patient has got no major bony arthritis, then I think that's a very justifiable option once you discuss with the patient that this we are doing and these are the benefits and risks behind it. So very right decision.
How about Australia, David? What do you think?
Again, I think that it's important to understand why this happened in the first place. There wasn't an injury, and that happened because the loads on that degenerative meniscus were too high. So if you just put it back to where it was, it's going to fail again. So the most important thing is the HTO. Okay. As far as adding the root repair, I think if you are comfortable doing a root repair and you can do it fairly easily, there's probably no downside, but I don't think it's anywhere near as important as the osteotomy. And I don't think there's any evidence it adds anything to the osteotomy. This person had a fairly nicely preserved knee, and it looked like he got a nice repair. So I think it's probably makes you feel better on the day, and there's no harm in doing it if you're good at it. If it's a 75-year-old, then I would be pushing, with that sort of joint, I'd be pushing non-surgical treatment for as long as possible, and they don't always fail. Sometimes they actually settle down and they're actually okay. So you give them a chance to settle down, and if they deteriorate quickly into arthritis, then it would be a joint replacement.
Anyone want to comment about centralization of the meniscus? Tahsin, you want to comment on this one?
I because the extrudation of the meniscus, I just try to take a little bit centralization, a little bit in the medial meniscal root tears. So that's my preference. Because, however, what we do when we check the MRI, we will see the extrudation again.
Yes. So Theo, Claudia?
I can tell you that the Japanese did a study on the HTO with or without meniscus repair and centralization. It really didn't make any difference after 3 or 4 years. They saw a slight difference on the X-ray gap, but really no clinical difference at all. So again, it's a theoretical benefit.
Okay. Tahsin, you want to close?
Yes. I would like to thank you to all. It was great to see you all, and it was a great discussion. I think we could give the messages about joint preservation, the importance of the osteotomies around to me. So I would like to thank you all. I would like to thank you, Bioventus and Joe Lane, for supporting this. And I would like to thank you, all the participants from all over the world. Hope to see you in the next webinar with better and with the new faculties. Thank you very much for joining us.
Thank you, Tahsin. Thank you, Reha. Everyone.
Enjoy.
See you all. Take care.
Thank you.
Thank you.